Laboratory evaluation of hemostasis. For hemostasis specimen collection, we're going to look at our patient management before specimen collection. So we're going to want the patient history and risk assessments. So obtain thorough history including bleeding risk, medications, and conditions that could affect hemostasis. For pre-collection instructions, we want to tell them to avoid caffeine and exercise for at least 2 hours before blood draw and avoid smoking for 30 minutes prior. Patients should also be inactive for 5 minutes before specimen collection to help stabilize hemostatic parameters. For materials needed for the blood collection, we have a needle selection, of course, so we would typically want to use a 20 to 121 gauge needle for routine collection. If necessary, you can use the smaller 23 gauge needle, but obviously the 21 and 20 are going to be your first options. We're typically going to use a light blue top tube containing sodium citrate anticoagulant. The sodium citrate binds calcium and prevents coagulation, which helps preserve specimen integrity for hemostasis testing. Anticoagulants in hemostasis testing. So as mentioned, we have that sodium citrate. That function is to bind the calcium ions to prevent coagulation. It also acts as a buffer to stabilize specimen pH. For the ratio, the blood to anticoagulant ratio is 9:1. So it's a 9-part blood and 1 part citrate. There is adjustments for elevated hematocrit of greater than 55%. So if there is a high hematocrit, it can increase the plasma to anticoagulant ratio, which could cause a falsely prolonged clot-based coagulation test. Volume of the anticoagulant should be adjusted downward to maintain a correct ratio. The adjustment, so where C, if you look at that calculation on there, so C is the volume of sodium citrate in milliliters, V is volume of whole blood sodium citrate solution in milliliters, and HCT is hematocrit in the percent. For EDTA, this is not usually used in coagulation testing, and that's because it chelates the calcium irreversibly, which prevents coagulation, but also interferes with reversible calcium-dependent assays. So in contrast, sodium citrate calcium binding is reversible by adding calcium chloride during testing. You could also use citrate theophylline adenosine, or CTAD. This purpose is to suppress in vitro platelet or coagulation activation during blood collection. Its use would be, it's really a specialized assay such as thrombin antithrombin complex test where in vitro activation must be minimized. For the venipuncture, some considerations. We want to avoid errors, of course, and certain ones to avoid is using a vascular access device such as an IV or a PICC line for coagulation specimen collection. This is usually discouraged due to the contamination risk. If vascular access devices must be used, we need to flush the device with at least 5 milliliter of normal saline before collection. We're also going to discard the first 5 milliliters of blood drawn to avoid contamination with flush solution or the heparin. We're going to collect blood into a syringe, then transfer to the appropriate tubes to maintain that anticoagulant ratio. For capillary puncture, it should produce a free-flowing blood drop without squeezing or milking the puncture site, which can actually cause hemolysis or tissue fluid contamination. This is often going to be used for point-of-care testing, especially when venipuncture is either difficult or just not feasible. For storage temperatures, we have ambient temperature. So most coagulation specimens are stable at room temperature, which is 20 to 25 degrees Celsius before testing. We want to avoid refrigeration or freezing before testing as it could affect test results. For storage times, for a prothrombin time or a PT, specimens should be tested within 24 hours of collection if stored at ambient temperature. Any delays beyond this may lead to a degradation of labile coagulation factors like factor 7. Activated partial thromboplastin time, or APTT, should ideally be tested within 4 hours of collection at ambient temperature for best accuracy. APTT is more sensitive to factor degradation than APT. There are certain tests we can do for platelet function. The first one is a bleeding time. This was a traditional test that measured in vivo platelet function in primary hemostasis. It assesses how long it takes for bleeding to stop after a standardized skin puncture. It is influenced by the platelet number and function as well as vascular integrity. This test has kind of been put on the wayside. We don't really do much with it anymore. There is now a newer one called platelet aggregometry, and this measures platelet aggregation response to agonist in vitro. This requires preparation of platelet-rich plasma from the blood samples, changes in light transmission through the PRP as platelets aggregate or are recorded. Whole blood platelet aggregometry uses whole blood rather than that platelet-rich plasma. It is more physiologic but less commonly used than the platelet-rich plasma aggregometry. Then we have the LUMA aggregometry, and this combines platelet aggregation measurement with adenosine triphosphate release assay. It assesses both platelet aggregation and secretion, so that granule release of the platelets. It's useful in detecting storage pool deficiencies and secretion defects. Agonists that are used in platelet function testing, so some common platelet agonists include ADP, collagen, epinephrine, arachidonic acid, and ristocetin. All right, so platelet aggregometry. So we have platelet-rich plasma. This method uses light transmitting aggregometry, and the platelet-rich plasma is prepared by centrifuging whole blood to concentrate platelets. As platelets aggregate in response to agonist, the sample becomes clearer, allowing increased light transmission through the plasma. The change in light transmittance is measured over time to quantify platelet aggregation. Whole blood platelet aggregometry, so this method uses electrical impedance aggregometry, and it measures changes in electrical resistance or impedance as platelets aggregate on electrodes immersed in whole blood. It does not require centrifugation or preparation of that platelet-rich plasma. It does provide a more physiologic environment by testing platelets in whole blood with red and white blood cells present. For platelet LUMA aggregometry, we have the clumping together of platelets in response to activating stimuli or the agonist. This is critical for the formation of initial platelet plug and hemostasis. For platelet secretion, the release of adenosine triphosphate or ATP and other substances from platelet-dense granules upon activation. Secretion amplifies platelet activation and recruits additional platelets to the site of injury. For sample requirements, you need a whole blood collected in tubes containing sodium citrate anticoagulant. For storage conditions, specimens should be kept at room temperature to maintain that platelet function and avoid refrigeration or delays to help preserve that platelet viability and responsiveness. Some conditions that can be detected from doing these tests is the effects of non-steroidal anti-inflammatory drugs like aspirin. These inhibit cyclooxygenase enzymes. This reduces thromboxane A2 production, impairing platelet aggregation. So platelet function tests detect this drug-induced platelet dysfunction. For platelet release defects, this will show defects in platelet secretion of granule contents upon activation, and this leads to impaired amplification of platelet aggregation and recruitment. This is detected by a diminished ATP release in LUMA aggregometry. Platelet storage pool defects, sorry about that, deficiencies or abnormalities in platelet granule content or numbers. It could be congenital or acquired, and can cause impaired platelet aggregation and secretion. Also is detected by reduced secretion responses on platelet function assays. Then you can also find platelet membrane defects, so abnormalities in platelet surface receptors. Examples can include that Glanzmann thrombocythemia, if you remember that, and Bernard-Soulier syndrome. So result in defective platelet adhesion or aggregation. This is going to be diagnosed by characteristic patterns in platelet aggregometry. You can also find acquired platelet disorders, so platelet dysfunction that is caused by systemic conditions such as uremia, liver disease, myeloproliferative disorders, or even certain medications. It may result in abnormal platelet aggregation or secretion patterns, and is detected through platelet function testing combined with clinical correlation. For clot-based procoagulant screens, we can do an ACT or an activated clotting time. So this is usually a point of care test that is used to assess blood coagulation. Its principle is it uses a particulate clot activator to speed up the clotting process. The purpose of this, it's usually used to monitor anticoagulation during procedures requiring heparin, like a surgery, like a cardiac surgery in particular, in dialysis. A prothrombin time, or a PT, this is performed on situated plasma. So the addition of thromboplastin, which is a tissue factor, and calcium chloride actually initiate the clotting process. The test will measure the time in seconds required for the formation of a stable clot. This clotting time reflects the function of specific coagulation factors. So for the procedure, the reagent and sample are warmed separately to 37 degrees Celsius. Both are going to be incubated for 3 to 10 minutes, then combined, and that's when the timing will actually start. When a stable clot forms, the timer stops and the clotting time is recorded. The coagulation factors detected in a PT, or prothrombin time, so it'll detect deficiencies in factors 7 and 10. PT is commonly used to monitor oral anticoagulant therapy with drugs like Coumadin or warfarin. For quality control, we must run normal and abnormal controls every 8-hour shifts to ensure test accuracy. For reporting results, results are recorded in seconds to the nearest tenth of a second. And then we have that INR we talked about earlier, or that international normalized ratio. This is calculated to standardize results between laboratories. The reference range for PT is generally 12.6 to 14.6 seconds. For diagnostic use, this is a diagnostic assay that is used when any coagulopathy or bleeding disorder is suspected. Some common conditions where the prothrombin time is useful is that DIC, liver disease, vitamin K deficiency, and deficiencies of those certain coagulation factors that we mentioned earlier, such as 7, 2, 5, and 10. For the screening value, PT has a minimal or really no value as a general screening test for coagulation disorders. For limitations, we have specimen and patient factors can affect PT results, including QNS, which is quantity not sufficient, because we have to have that certain volume ratio. If they have a high hematocrit of greater than 55%, so a high red cell concentration can affect plasma volume and that anticoagulant ratio. If the specimen is already clotted, we cannot perform the test because the clot's already there. Then we have activated partial thromboplastin time, or APTT. This is performed on saturated plasma, and this test involves adding phospholipid, particulate activator, and calcium chloride. These components initiate the intrinsic and common coagulation pathways. The time taken for the formation of a stable clot is measured in seconds. This time represents the APTT result. So for our procedure, we have the reagent preparation. So the phospholipid and particulate activator are warmed and incubated at 37 degrees Celsius. Then the sample mixing. So the incubated reagent is then mixed with the patient's saturated plasma, which has also been incubated. For the incubation, the mixture, all of them together, is then incubated for 3 minutes at 37 degrees Celsius. For initiation, the calcium chloride is forcibly added to the mixture to trigger clot formation. For timing, the timer is started immediately once the calcium chloride is added. The timer will then stop once that stable clot is formed. The clotting time is recorded in seconds, and that is what the APTT is. The APTT can detect deficiencies in factors involved in the intrinsic and common coagulation pathways. So common clinical indications for ordering APTT would be if they're suspecting a hemorrhage disorder, like unexplained bleeding, recurrent thrombosis, like clotting events, or maybe even for a suspected autoimmune disorder that could affect coagulation, like lupus. For quality control, we're going to again run that normal and abnormal control every 8-hour shift to help ensure test accuracy and reliability. For a reference range, a normal APTT is going to be 26 to 38 seconds. We can also do heparin therapy monitoring. So a therapeutic range for patients on heparin therapy for APTT is actually 60 to 100 seconds. APTT is widely used to monitor unfractionated heparin anticoagulation. Then we have thrombin clotting time. This measures the time for fibrin formation caused directly by the action of thrombin. Thrombin catalyzes the conversion of fibrinogen to fibrin, which is the final step in the coagulation cascade. A standardized concentration of thrombin is added to the saturated plasma, and then the time once again in seconds until fibrin clot formation is recorded. The thrombin clotting time evaluates the final common pathway of coagulation. So the procedure, it is very similar to the PT procedure. So the reagents in plasma are warmed to 37 degrees Celsius. The reagents and samples are incubated separately, and then they are combined and timed until that clot is formed. Once again, quality control is ran normal and abnormal every 8-hour shift. For reporting results, the typical reference range is 15 to 20 seconds. For interpretation of results, so if you have a prolonged thrombin clotting time, this can be indicative of hypofibrinogenemia. Could be that there's a presence of fibrin degradation products and also the use of direct thrombin inhibitors or heparin contamination or presence. If it is normal or shortened, it's usually not clinically significant. So we're just kind of looking, if it is prolonged. For fibrinogen assay, this measures the ability of fibrinogen in plasma to form a fibrin clot. Clot formation is induced by exposing the plasma to a high concentration of purified thrombin. For the procedure, we're going to prepare a 1 to 10 dilution of patient and control platelet poor plasma using the Owen buffer. We're going to warm the diluted samples to 37 degrees Celsius for 3 minutes. We're going to add that thrombin reagent and start the timer immediately. Once the timer stops, it will stop when a clot is formed. The clotting time correlates inversely with fibrinogen concentration. For quality control, we're going to run normal and abnormal controls with each batch that is ran, since this is typically not something that is ran all the time. So each time you get a test for this, you're going to run that control. Reference range for fibrinogen is 220 to 498 milligrams per deciliter. There are some limitations to this test, such as exposure to sunlight or oxidation, which can cause thrombin breakdown, which can affect the results. And also if there's any presence of unfractionated heparin, greater than 0.6 units per milliliter, or fibrin degradation products greater than 100, it can lead to falsely low fibrinogen results. Tests for fibrinolysis, so we have that D-dimer assay we've talked about, and then we also have fibrin degradation product. So the D-dimer assay, this is detected using an automated turbidimetric immunoassay. The assay uses monoclonal antibodies bound to latex beads to detect D-dimer fragments in plasma. So when D-dimers are present, it binds to antibodies causing turbidity, which is measured. For clinical implication or applications, this is used to detect and monitor conditions involving fibrin formation and breakdown, such as in DIC, systemic fibrinolysis, deep vein thrombosis, and pulmonary embolisms. For the fibrin degradation products, or FDP, so this assay detects circulating fragments of fibrinogen and soluble fibrin in plasma. These fragments are produced during fibrinolysis and clot breakdown. For the interpretation of results, the test is calibrated to detect the fibrin degradation product at concentrations of 2 micrograms per milliliter or greater. Detection is based on the appearance of visible agglutination in the assay. This can be used primarily, it's used to diagnose and monitor disseminated intravascular coagulation, or DIC.